and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services, and Mr. Vijay Kumar, Zonal Sales Manager, North Zone, from Naari Division of Jagsonpal Pharmaceuticals Ltd, are very delighted to welcome you all to this webinar on ovulation induction, organized by the Indian Fertility Society Haryana chapter and Rewari Obs Gyn Society, with academic partner Naari Division of Jagsonpal Pharmaceuticals Ltd, makers of PRORETRO, 10 mg tablets of indigenous micronized dydrogesterone, assisting motherhood, delivering happiness. We also present Cystelia M, formulated with ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women, and Endoreg 2 mg tablets of Dydrogest for the management of endometriosis. A warm and hearty welcome to all the esteemed faculty and attendees. Dear attendees, if you have any questions, suggestions, or clarifications, please post by the text in the Q&A box. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now we request the convener of program, Dr. Seema Mittal, Treasurer, Indian Fertility Society, Haryana chapter, to initiate the program. Over to you, ma'am.
Thank you, Amitji. Good evening, friends. Welcome to this webinar. Friends, with the increasing need of fertility treatment all over the world, now we know that ovulation problems are a common cause of infertility. Until the early 1960s, there was hardly any treatment for infertility. All we could do was just the psychotherapy and counsel the patient. So it was in 1960, 1970 that a veritable avalanche in the form of drugs and methodology came. So 1961, we saw Clofert coming, 1970s, the gonadotropins, and 1980s, finally, the gonadotropin releasing hormones. So this was such a wonderful ray of hope for all our patients, but still there are areas where we still lack our knowledge. So today we will have the wonderful speakers who will throw light not on the well-known, but also the lesser-known facts. So I take this opportunity to invite our Secretary Haryana chapter, Dr. Sonu Balhara, who is the head of Reproductive Medicine Artemis Hospital, Gurgaon, and she's in charge and unit head. Over to Dr. Sonu Balhara to welcome all our faculty, attendees, and the team Jagsonpal. Over to you, Dr. Sonu.
Thank you so much, Seema. Very warm welcome to all our viewers and our esteemed faculty. I welcome you all on behalf of Indian Fertility Society Haryana chapter and Rewari Obs Gyn Society for this webinar on a very basic topic which is very important to all of us on ovulation induction. And I thank Jagsonpal for being a partner with us. And thank you so much, Seema, for organizing everything. Over to you to start the academic session.
Thank you, Dr. Sonu. So, friends, we have a speaker for the evening, Dr. Fessy, who needs no introduction, but we have our esteemed chairpersons. So, I will request Dr. Anita Khan, ma'am, who is the head of OBGY Department, Asian Hospital, Faridabad. Ma'am is very senior and she is chairman in her department. And she's president IMS Faridabad and she's patron FOGSI. So over to you, Anita ma'am. It's really good that you spare time in spite of being so busy today. And ma'am, please introduce our esteemed speaker to all our attendees. Over to you, Anita ma'am.
Thank you. Thank you, Seema, and thank you, Dr. Sonu, for inviting me. Dr. Fessy is head of the Department of Reproduction, Medicine and Surgery both in AMRITA Institute of Medical Sciences, Cochin, Kerala. He was the FOGSI Vice President 2021, ISAR National Executive Member, ICOG Governing Council Member 21-22, Vice Chairperson Kerala Chapter IAGE, Secretary Kerala Chapter of ISAR, Executive Member Kerala Chapter IFS, Reproductive Committee Chairperson KFOG, All India FOGSI International Academy Exchange Committee Chairperson 2013 to 15, Secretary General of Kerala Federation of Obstetrics and Gynecologists 2012 to 2018, Member FIGO Reproductive Medicine Core Committee in 2013 to 2014, SAFOG Executive Committee Member and Journal Editorial Board Member 2013 to 16, Vice President KFOG in 2019, Editor KFOG Journal and Website 2009 to 2011. He has received various awards like FOGSI Corion, Kamini Rao Yuva Ovulator, Imaging Science Awards, Praveen Mehta Fellowship in Endoscopy, Stuti Rudra Prize in Endoscopy, Kumud Tabaska Research Prize in Infertility. The list goes on and on. But Dr. Fessy Lewis is very famous in this field, and everybody knows him. So let's go over to him without wasting any time. Thank you.
So, good evening to all of you. First of all, let me thank the IFS, Indian Fertility Society and the Rewari Obs Gyn Society for inviting me. I think the topics today is so relevant, so that is very, very important in our clinical practice. So basically, today topic allotted to me is revisiting IVF stimulation. So anything when we start about IVF stimulation, we have to always start by this diagram which you have studied from the undergraduate time. I think you must be all knowing about the hypothalamus pituitary ovarian axis, that is the HPO axis, what we always know from our undergraduate time. So from the hypothalamus, GnRH is produced in the pulsatile fashion, and if that pulsatile fashion is from the pituitary, FSH and LH is produced, and with this the ovaries will respond by producing the estrogen. It has got a negative and feedback effect also. So basically in infertility practice, what we have to think about the ovulatory disturbances, and this is the most important WHO classification. That is, one is the hypogonadotropic hypogonadism, and group 2 is the normogonadotropic normoestrogenic group, where the most of the people fall, it is a PCOS group, and lastly is the hypergonadotropic anovulation, which is the primary ovarian problems. So basically, we have to know about the hypogonadotropic hypogonadism patients, where the FSH will be low, LH will be low, and estrogen also will be low. These patients need a higher dose of gonadotropins right from the beginning, especially combination of FSH and LH. You have to start with minimum of 150 or 225 unit, and you have to go the stimulation, whether you are going for normal stimulation or IVF stimulation. And one advantage with hypogonadotropic hypogonadism is that in infertility, we need not need a suppression for that. We can straight away start, but it is always to have a withdrawal bleeding with a cyclic low-CPL and then start. That will be better. But they need not have, it is hypogonadotropic patients, so they need not have to have a suppression like the other patients. So these patients we have to identify properly, and non-IVF, we have to counsel that stimulation can go for. Basically, today's discussion is IVF, so we'll be sticking mostly to the most common patients, that is type 2 patients. So in PCOS patients, basically, where does the ovarian stimulation comes? That is after the lifestyle stimulation. Next is the ovulation induction, and metformin, other insulin sensitizing agents. Definitely not only the ovarian stimulation, it has found to be really useful in the 1 second. So basically, that will not only for the other part, it will help in the decreasing the hyperstimulation incidence. Definitely, it will be useful. And laparoscopic ovarian surgery, just put to show the completion sake of the management. And lastly is the IVF comes in the PCOS patient. So that different of the diagnostic criteria of PCI, I'm not going to that, but I just put it to emphasize the diagnostic criteria, because this is according to the latest criteria. There must be FNP of more than 20 per ovary, and the ultrasound has to be at least 8 megahertz. That is most important. Just because of some other outside diagnosis as PCO is not enough. And according to this latest criteria, the IVF comes as the last part after the ovarian stimulation, and comes the last part only. So if you look at the different ovulation induction, basically it will be to correct the disovulation or anovulation, for superovulation for IUI, and basically the control ovarian hyperstimulation, that is for IVF. So let us see what is this control over hyperstimulation. Just now we discussed about it is hypothalamo pituitary ovarian axis, and from the hypothalamus GnRH is produced in the pulsatile fashion, and with this from the pituitary FSH and LH is produced. And when in control over hyperstimulation, that is for IVF stimulation, when we give exogenous GnRH agonist or antagonist, when we give agonist, initial flare-up effect is there, then this pulsatile fashion of GnRH is not there. When it is not there, there is not FSH and LH from the body, and we have to give exogenous FSH. But when we give GnRH antagonist, there is direct suppression of the receptors without flare-up effect, and then we have to give exogenous FSH. And when the follicles are ready, we give HCG, and before it ruptures, we retrieve the oocyte. That is the routine stimulation. So this is the typical long protocol, where we desensitization, because initially there will be a flare-up effect, and after that, once the periods comes, make sure no residual cyst is there, endometrium is thin, and then we stimulate by giving the gonadotropins, and we continue the agonist. It is a depot. The action will be lasting till the time of HCG or the daily injection we have to see. So the whole purpose of ovarian stimulation with gonadotropins for IVF is to stimulate the follicles. So this is the long protocol. Instead of that, we can start on the day 2 and 3 without a desensitization. We can start that. That will produce slight flare initially. That will be utilized, and that is how the short protocol work out. But the problem with the short protocol is that there can be uneven follicles, and with the advent of antagonist stimulation, that has gone out. So either long protocol or antagonist protocol. Short protocol is not much used because the oocyte quality is not less. So we won't be discussing much about the short protocol. So the purpose of gonadotropin is to initiate and maintain the follicle growth, may be achieved by transient increase of FSH above a threshold dose. That is important, above threshold dose for sufficient duration to generate the limited number of follicles. So when you use gonadotropins, be it the normal stimulation or the IVF control ovarian stimulation, we can go for a hyperstimulation. So let us look next about the antagonist protocol. Antagonist protocol, what we saw initially was the long agonist protocol, a long or short protocol. In antagonist protocol, we give gonadotropins from the 2nd or 3rd day, and when the follicle is become 13 or 14 millimeter, or by the after 5 days, that is a fixed regime, we add the GnRH antagonist. So without flare, it directly suppresses. When the follicle is 2 or 3 follicles of 17-18 millimeter, we give HCG. Usually the HCG that is given, and before the follicle rupture, we take out. That is a routine antagonist protocol. I'll come to the agonist trigger afterwards. So coming to the gonadotropins, what you use, we can use HMG preparation, which contains FSH and LH, or highly purified urinary FSH, where the HMG FSH is more, and 1 unit of usually LH will be there, and it is more purified. A recombinant is that by recombinant technique, we are manufacturing the gonadotropins FSH, so there won't be LH, so it will be, and the batch to batch consistency will be there. But what does the difference? No difference in outcome between the HMG or recombinant FSH when used in conjunction with a long GnRH agonist protocol or PCOS, and there is no significant live birth rate, miscarriage rate, or multiple pregnancy or OHSS rate. So ovarian stimulation, our aim must be to get the live birth, prevent the complications. So what are the complications what you can occur? One is the OHSS, another is the multiple pregnancy. Multiple pregnancy in IVF we can limit to some extent by restricting the number of embryos we transfer. We can restrict to 1 embryo or even 2 embryos, so the multiple pregnancy can be minimized. So particular we can reduce even to go for a single embryo transfer. So next is how you prevent the OHSS. One, with the experience of ovarian ovulation induction therapy and recognition of the risk factors, we have to individualize the ovarian regime and use minimum gonadotropins to achieve the therapeutic goal, which can prevent the OHSS. So next, how we can, as generally we can look for the basic hormones like FSH, anti-mullering hormone. AMH tells about the ovarian reserve. Also, estradiol and inhibin has been reported. Inhibin is not much used in our country, but estradiol, if it is high, that means that it can predict poor ovarian response. Or if there is a cyst, residual cyst is there, we can see whether it is hormone producing by seeing the estradiol. And the ultrasound markers is that one is the antral follicle count, and there is ovarian volume. Ovarian volume has not found to be that much useful, but antral follicle count definitely has been found to be really useful in predicting the poor response or the hyper response. So by seeing the different parameters, how you can choose the different stimulation protocols. We just told about the antral follicle count. So if it is more than 8, you can predict good response in the normal patients, high levels in the high responders, and ovarian volume, even though cutoff is told as that is not much studies supporting that. So antral follicle counts, different studies tell differently. Some studies tell if it is more than 14, it is got a high specificity of a hyper response. And as the limitations is it is quantity, it assesses the quantity but not the quality, and there is inter and intra observances may be seen, and intercycle variability will be there. So there can be differences in the different cycles and according to a different and next is that ovarian volume. I told no, that is not found that useful by the studies, and ovarian blood flow has got limited use. But another thing what we can use is the AMH, but the limitation is that there is a lack of standardization of the AMH assessment at the different labs. And it can be there is no international reference standard for AMH to predict the hyper responders. So there is different methods of doing like the immunotech Beckman method, or their DSL kit is there, but there is no standardization. But this reference value where what we can usually also picomoles also has been there. But regarding the hyper responders, there is no reference. Some tells that if it is more than 5.4, it is some. There are now some studies telling if it is more than 3.5 nanogram, we can predict can go for hyper stimulation. And regarding the FSH, there it is a late sign of a reflective of the decreased granular cell function, and does not explain oocyte quality decline to some extent. And E2 value, as I told, no, it does not predict about the hyper response. Inhibin has got a limitation. So to summarize how the ovarian response, to combine the most important ultrasound, especially antral follicle count, and also when we combine with basal FSH value, we can predict that the response of a hyper response with and we can adjust the stimulation whether it is PCO or the poor responders according to that. Age factor is definitely is there. As age increases, all the studies tell that the oocyte quality, oocyte number, everything comes down with the age. So if you look into the three main things, predict hyperresponders, AMH and AFC is useful. To predict poor responders, AMH, AFC and FSH also can be useful. Age is minimal use for both the things. So that is how we can use the AMH, FSH and AFC to predict the poor responders and hyperresponders. So coming to the ovarian monitoring for ovarian stimulation, we have to do under the transvaginal sonograph to look for the number and size of the follicles and pattern and the thickness of endometrium. And if suspecting the patient going for an hyperresponse or the inadequate response, then we have to do E2 value. Otherwise, it is not mandatory, but if a routine, if we are doing cases, we can make it a mandatory to see in a serial specific interval to see the E2 level of that patient. So basically, we have to go for a serial ultrasound level. The dominant follicle is told if it is more than 70 millimeter, endometrium at least 8 or 7 millimeter. And coming to the HCG for controlled ovarian IVF stimulation, always it is recommended for 10,000. Even though some studies tell 5,000 is enough, but most of the people get good result and go for a 10,000 unit. So ovarian stimulation is with gonadotropins. If you look into the literature, it has been started over years, and the recombinant FSH started in 1996. Recombinant LH came afterwards, and then the poly-alpha polytropin is there, and in the pipeline is the oral gonadotropin is there. So when we look into the long protocol, which we already discussed, that we have to use desensitization, and when the follicles is ready, endometrium is ready, we can give HCG and retrieve the oocytes. And short agonist protocol is that from the second, third day, gonadotropins and the agonist, and the antagonist we use. This is after 5 days of or 6 days of stimulation, that is the fixed regime, or when the follicles is 30, that's a flexible regime. And in India, it's only single dose regime is, multiple dose regime is available, where we give 0.25 milligram. But in some European countries, single dose, that is a 3 milligram preparation is available, which lasts for 3 days. And the commercially available antagonists are cetrorelix and ganirelix. And what was the main advantage or the change which antagonists produce our infertility or IVF practice is that it doesn't have the flare-up effect, and it's directly antagonists block the GnR receptors in a dose dependent fashion, which is a competitive fashion. I told about the fixed protocol and the flexible protocol. The advantage is that how it is producing of the HPO axis without producing the flare-up effect. But people were very skeptical initially when it was started, how this will be useful in their clinical practice. So one thing is that whether it will really reduces the hyperstimulation syndrome. So initial incidence of OHSS was lower in antagonist protocol. That was initial slightly lower only in the 2010 study which came in human reproduction. And definitely this is the one Cochin trial which came in 2011, 8 trials of 783 PCOS woman versus, and they told us the inference was it was 10% less with that, but even then hyperstimulation was occurring because HCG was using a trigger. So afterwards it started about around 2011-12 that GnRH agonist was tried for triggering instead of HCG. That means you use 0.2 milligram, 1 milligram of leuprolide for final oocyte maturation. So how does that act? Already the receptors will be blocked by the antagonist. So this agonist or receptor affinity. So agonist is capable of displacing the antagonist from the receptors and inducing the activation, that flare-up effect, which usually occurs with the agonist, and that is used for the LH surge and FSH surge occurring, that will produce the final luteinization, and we can oocyte maturation can occur. So how does it has been evolved over the years? You can see this is a 2002 Cochrane review published by Al-Inani and Yusuf and Abulgar. And so they're telling that the new GnRH antagonist protocol with in a short and simple protocol with lower pregnancy rate compared to the GnRH agonist long. So when they started initially, the success rate was told to be less with that. There is no significant difference between the both protocols regarding LHR prevention of OHSS. That is what it was told initially in the 2002. So this is another study which came a few years later. That means the probability of the live birth after ovarian stimulation for depend on the type of analog. That means both when we are using GnRH agonist and antagonist, the incidence is found to be similar. This is which came in 2006. Initial was 2002, and this is 2006. So that is the author's conclusion was GnRH agonist protocol with simple protocol, which is good clinical outcome with significant reduction in the incidence of OHSS. That is what the compared to the initial 2002, that was the inference in 2006. This is the and also the total number of ampules used for gonadotropins also was found to be less in that, and the total duration of the gonadotropins also found to be less. So their opinion was that how does that over the years it has been evolved. This has been evaluated by George Grisinger. That tell that most of the centers have got inexperience with the use of antagonists. Use of antagonists were restricted to higher age groups with poor responders and patients with unfavorable prognosis. But as it evolved over years, this is what the RCT of a Cochrane review of 45 RCTs came in 2011 with comparable live birth to the agonist protocol and highly significant reduction in the OHSS. That was the incidence of the Cochrane review, which came in 2011. If we look into the ASRM guidelines, which came in 2010 for the strategies for the prevention of the OHSS, one of the strategies was GnRH agonist that reduces the risk of OHSS, reduces incidence of OHSS, hospital admission, reduces the need for secondary interventions such as posting or cycle cancellation. Posting means withholding the gonadotropins, and cycle cancellation is cancelling the cycle. But still, there was incidence of hyperstimulation was there. But next evolved was that over the this is what we came in 2010, and that they were telling that when we try GnRH agonist trigger for antagonist, like what we showed about GnRH agonist will displace the receptors, it will very significantly reducing the ovarian hyperstimulation syndrome that was being told. So over the years, by 2014, this was focus on human reproduction by the Esche group. This agonist triggering is viewed as one of the major advances in the ovarian stimulation with potential eliminating the OHSS. And over the, you can see that in Europe, nearly this is a data about 5 years back, 32% of the units changed into antagonist protocol. But what is the main drawback of that? The ongoing pregnancy rate was less when we transfer in the same cycle, because luteal phase and insufficiency is more. That is the main advantage was that. So we had to need an facility to the freeze oocyte or freeze embryos and transfer in subsequent cycles so that the pregnancy rate is good. Studies came as one single shot or small dose of HCG can be given in the luteal phase, and we can transfer in the same cycle, but that will take out the advantage of preventing the OHSS. That's why it is not that popular unless it is a dire emergency. But endometrial receptivity is not affected. That is in the oocyte from each donor shared from 2 different recipients, and it was found that there is not much difference in the implantation rate. So agonist will not hamper the endometrial receptivity. That is clearly shown by this study. But only thing is that luteal phase defect will be there. That is one which is affecting the pregnancy rate. So in IVF stimulation, we have to always identify the patients at risk. If it is a patients at high risk, if it is young patients with PCO ovaries, with thin-billed patients with more follicles with a typical necklace pattern, and if there is a HCG for luteal support and ovulation induction with protocol with history of OHSS, that is more important, and the estradiol level of more than 4,000. There is no proper cutoff value above which E2 value you can have hyperstimulation. Some people some centers take it as 3,500 as the cutoff value which can occur. So this is the practice committee of the ASRM in 2016 telling that associated with the risk B of OHSS is one is IMH value more than 3.4, AFC more than 24, development of more than 25 follicles with stimulation, estradiol value of more than 3,500, and or more than 24 oocyte retrieval. So this is what difference, but at least you must know the basic thing how we can predict, and this is more accepted is that ASRM criteria which can predict with the grade B evidence. So the next advantage what has come about with the antagonist protocol is that we can use for the minimal stimulation and mild stimulation. We can go for gonadotropins, clomiphene, followed by gonadotropins. Anytime we can, if the follicle is more than 13 millimeter, we can add that. So with the advent of antagonists, we can use that antagonist in the stimulation at any time with minimal stimulation or mild stimulation, where the dose of gonadotropins or whether we use clomiphene and letrozole is, we can add the GnRH antagonist. Same thing we can use by, if you wanted to convert into IUI stimulation to IVF, we can use the antagonist and convert into that. So next thing is that we can use OCP pre-treatment with that, but there are some recent studies that OCP more than 14 days, it can really affect the pregnancy rate, but there is only smaller studies. It is there. We have to need a larger studies, and low dose Cetrelix protocol people have tried. I'm not going to that. So when we compare the long agonist protocol and GnRH antagonist protocol, there is no flare-up effect with possible cyst formation which can occur with the agonist protocol. There is it can be integrated more. We can exclude the early pregnancy compared with the agonist protocol, where the under suppression patient can conceive. And if there is hyperstimulation, we can prevent hyperstimulation by giving the agonist trigger and free or but there is a drawback is that uneven size of follicle formation can be there. The net number of embryos available for freezing may be less with the antagonist protocol. So advantage is that shorter duration of treatment, less injection, less consumption of gonadotropins, no flare-up effects, formation, no pituitary desensitization, which is more physiological, less incidence of OHSS. So let us see what are the international evidence-based guidelines for assessment of PCOS tells gonadotropin releasing hormone in women with PCOS undergoing IVF treatment, gonadotropin releasing hormone antagonist protocol or gonadotropin releasing hormone agonist long protocol. The most effective is for improving the fertility outcome in women with PCOS GnRH antagonist IVF treatment. the use of HCG trigger or GnRH agonist trigger is the most effective for improving the fertility outcome. But the recommendation is that final oocyte maturation with GnRH agonist and free salt suitable embryos would be considered in women with PCOS having IVF FOGSI cycle with the antagonist protocol and at least increased risk of developing OHSS. So this I put separately again because this is what the latest SRM recommendations which has come about 3 years back is recommending. And they recommend the choice of FSH in women with PCOS undergoing control over hyperstimulation. The choice of effect, their urinary or recommend FSH can be used with women with PCOS undergoing control over stimulation. There is no much difference between whether we are using the urinary or recommend FSH. And in women with PCOS undergoing control over hyperstimulation or IVF, exogenous LS treatment during IVF FOGSI effect is effective for improving fertility outcome, but should not be routinely used in combination with FSH hormone therapy in women with PCOS group. It can be used. And next recommendation, according to that criteria, is adjuvant metformin in women with PCOS undergoing COH for IVF. Adjuvant metformin is effective for improving fertility outcome, and metformin is found to be effective if you are using 1000 to 2500 milligram daily, and it is found to be having a side effect, but it is found to be decreasing the OHSS rate. And regarding in vitro maturation, that means we treat the oocyte at the early stage. That can reduce the OHSS, but it is not found to be very much useful. So let us see over the how the IVF stimulation evolved over the years. We saw how the gonadotropins evolved, and what happened in the last 10 years. What is the new things which has come in IVF stimulation? One is the long-acting FSH, other is FSH biosimilars, and another is a luteal phase support subcutaneous progesterogens. And newer protocols is that minimal number which has evolved, and minimal number of injection, and we can use as a progesterone for LH surge, flexibility of starting the control over stimulation, double over stimulation, double triggering, and individualization of starting the FSH dose. We will go each one by one. And one is the long-acting FSH, that is known as colifolipropin. It is available as Elonva. It is not yet marketed in India. It is by recombinant DNA technologies that the single dose FSH level above the threshold necessary to support the multiple follicular growth for 7 days. So it reduces the number of injection, especially if you are using with the antagonist protocol or even an agonist protocol depo preparation. Initial, you need not have to bother about daily injection for the first 7 days. The purpose is increases the threshold level, and that is being sustained for 7 days. So you need not have to give daily injection. So the colifolipropin alpha reduces the number of necessary injections. So if you give initial 1 injection, if you are going for antagonist, we can give afterwards, but we need not have to. We have to repeat it afterwards after 6 days only. So there are 2 studies which has come with that, engage and ensure with a reasonably good pregnancy rate. So larger studies and Indian studies is needed for that. So advantage is single injection, reduce the burden, treatment burden, safe, and less error in administration outcome comparable with the currently available protocol. And next, what has evolved in the last few years is the FSH biosimilars. So there are a lot of biosimilars are come. Some are good, some are not good. But over the years, that has made the IVF treatment cheaper and biologically or clinically non-inferior to the original product. Next is the subcutaneous progesterone. What in Indian population which were not keeping the vaginal gel preparation properly, we had to rely on the progesterone which was oil-based, Now it is, I mean, subcutaneous water-based preparations are there. Even though it is recommended as 25, most people use as 50 milligram. And just like vaginal capsule, it is 200 milligram twice daily. It is 50 milligram. It is being routinely practiced, even though it is the recommendation is 25 milligram. But that has reduced the pain to the patient to a greater extent, and patient tolerability for the repeat procedure if needed is much more with that. And next is that we have to look into the after the biosimilars, after the progesterone is the new protocols. So here, initially, along with that, long-acting FSH is that depot preparations, initially very few depot preparations were the which was really giving long effect. But with the advent of the modified technology of the depot preparations, we are getting good suppression if we are using long protocol. And along that, if you have long by acting FSH, the number of injections is less. And the evolved is the progesterone to block the LHR. That is, if you have medroxyprogesterone 10 milligram along that gonadotropin, and when you use daily, beginning from the day 3 till the day of triggering, it will effective in as an oral alternative for and prevention of the premature LH surge in women undergoing control ovarian stimulation. There are few studies which has come. So larger studies, which first study came in 2014. Larger studies is needed so that how far we can routinely avoid the agonist or the antagonist for the suppression of the HPO axis. Next is the flexibility in starting the ovarian stimulation at different phase that we told. Single cohort of the antral follicles grows. Initial tradition that it was at the beginning of the follicular phase. Recently, it has been demonstrated that there are 2 or 3 waves of the follicular growth. So even antral follicles start occurring the luteal phase also. And this is the principle of using the emergency fertility preserver. Suppose the patient is diagnosed of malignancy, they come anytime, we can say that is a random start protocol. The number of yield of the oocyte may be less, but when they don't have much time before the starting any chemotherapy or radiotherapy, we can go for a random start or emergency IVF. That is the but accepted where it's a random start protocol can be used, and this has been very effective with the advent of the antagonist for suppression also. And we can phase, a late follicular phase, and luteal phase also. And if you are using antagonists for suppression, you can try with the GnRH agonist or HCG can be used. And there are some studies. This is one study by Quinn et al. In 2016. There is no difference in the early follicular, late follicular, luteal phase with the number of mature oocyte retrieved. But this also main important is that the clinical pregnancy rate and implantation rate is similar with all the group. Even the other studies tell the number of oocyte obtained is less with the late follicular and luteal phase random start protocol. Next is the dual or duplex ovarian stimulation. Especially the most accepted is the Shanghai protocol, where 2 subsequent controlled ovarian stimulation courses in the follicular luteal phase are given, retrieving more oocytes in the controlled ovarian stimulation second. And the advantage is that when we give the initial stimulation, it recruits as few follicles that is being stimulated, especially in poor responders. This Shanghai protocol is being given. And initially, when we give clomiphene or letrozole, and it has been continued till we give the GnRH agonist. People have tried HCG trigger also, but more accepted is the GnRH trigger. And after the oocyte retrieval, again, we give clomiphene or letrozole, and stay along with that gonadotropins after started after a few days, and again is given, and second oocyte retrieval is done. People have modified it in different way and done, and some people have just used antagonists instead of continuing with the clomiphene continuously in the second phase. So their yield is more in the second stimulation. Next is that that is what I told, D-secret protocol were two antagonist protocols. That is, one control over stimulation started on the day 6th after the where the antagonist started on this after stimulation started on the 6th day post OC pill, and after the first pickup again the second stimulation is started, and the trigger is given by both the stimulation. And according to this study, which came in 2015, similar number of oocytes and blastocysts in both the stimulation. But the main advantage is that there is twice as many number of oocytes and blastocysts in a 4 weeks time frame, which would be useful, especially in a poor responders. And next thing what is evolved over years is the double trigger. That means GnRH agonist together with reduced or standard of HCG is given. Some people give GnRH agonist in 40 hours and GnRH 34 hours prior to the oocyte retrieval. The indication is that the previous history of empty follicle syndrome or poor responders and statistically significant increase in number of retrieved oocyte and mature oocyte can be obtained. It's also larger studies is needed. And in higher responders, people are tried with GnRH agonist with reduced dose of HCG, which improved pregnancy rate. Normal responders, GnRH agonist and standard dose of HCG. That means same dose of agonist and same dose of HCG together, which are improved the live birth rate. So here also larger studies is needed with that. So next is that people have tried evolved over years how to individualize the FSH dose, especially to prevent the OHSS. There are several strategies coming in several articles. This is one very interesting thing which came by Fisher et al. In 2016. They are looking to the PCO status, age, AMH, BMI, history of previous choices to decide the dose. And they formulated with if there is PCOS, how you if it is non-PCOS diagnosis, it is routine. If it is PCO diagnosis, look into the age, whether it is less than 30 or 30 to 40 or more than 40. According to that, you decide the dose as 75, 100 or 150. And along with that, if it is the AMH is less than 0.7, you add 50. But if the BMH is thin patients, you minus 25. And this is if the same thing, if the AMH is more than 5, you decrease 25, or otherwise it is less than 3.5, you add 25 unit only around that 75. And next thing is that if according to the BMI, if it is BMI is high, we have to add 50 units. So if it is PCO group, look into the age, look into the AMS, and look into the BMI and titrate the dose. And especially if there is previous moderate or severe OHSS, we have to decrease the dose. And like that, we have to titrate the dose individually to prevent the hyperstimulation. And this is what one study. And
good evening, Dr. Fessy. It will be better to wind up in a few minutes.
Okay. This is what the schematic representation by the Asso group. They are telling about the AMS and how the ultrasound markers and AMH is being for the low responders, normal responders, high responders. This has came recently in 2020. And lastly, if it is a hypergonadotropic hypergonadism, poor response, what we can do. There are a lot of studies supporting the growth hormone use. People have tried DHEA, but it's mixed response. And there are some studies promising testosterone gel we can give the pre-treatment. If you are using gonadotropin, you have to start with along with that stimulation. Most of the Western studies are with the 8 units or 12 units. That is very costly. We have tried for last 10 years using tools along that gonadotropins in poor responders where we are using HMG and giving reasonably good result. So newer gonadotropins in the pipeline is the oral gonadotropins. So to conclude, the first test baby Louis Brown, and as delivered a baby in 2006. So even the first IVF baby is delivered. A lot has changed in the understanding and the management of IVF ovarian stimulation. Yet we are in a long way to go. So before starting ovarian stimulation, if we have to define the goal of ovarian stimulation and for that patient and analyze the ovarian reserve if needed and select the correct stimulation protocol before starting the stimulation, and the search for the new drugs, refinements, and adjustment of ovulation induction regimes with the purpose of finding ideal protocol that combine efficacy, safety, economy, and good patient compliance and excellent clinical outcomes continues. And this is an ongoing process. And thank you for patient hearing.
Thank you, Dr. Fessy, for the evidence-based presentation. It was a brilliant presentation. Over to Savita Singhal ma'am to conclude this session. Savita Singhal ma'am is the professor and unit head at Medical College, Rohtak, and she has over 30 years of experience. Can we have ma'am's CV? Because she's 27 years of teaching experience, over 150 national publication to her credit. She's delivered lectures and she's master trainer, good scientific writing. Ma'am is member of editorial board of CRO and she is reviewer for European Journal of OBGYN and British Journal World Health Bulletin. And her field of interest remains adolescent gynecology and oncology. Ma'am is just a one call away, be it patient, be it any other problem. Over to you, ma'am. It's our pleasure that you have spared time to be with us in spite of your busiest schedule. Over to Savita, ma'am.
At the outset, I'd like to thank Dr. Seema and Dr. Sonu Balhara for giving me this opportunity. And thank you, Dr. Fessy, for very elaborate, exhaustive session on the ovulation induction protocols in PCOS. You have very, very elaborately explained how we can decide the poor responders and hyper responders by the AMH, AFC, and day 3 FSH inhibin levels. And especially we have discussed the antagonist protocols, recombinant FSH, and adjunct metformin are very, very good for the patients of PCOS, and very excellently explained about the long-acting FSH where minimal injections are required. One question, Dr. Fessy, to you. If it is all about the IVF, if a patient comes to a general practitioner, PCOS, so which drug you will prefer, clomiphene, citrate, or letrozole? Not
that
going
means
for the IVF, just for the ovulation induction. Yes.
If the patients with for PCOS come, I think right now we'll be using. It is recommended to use letrozole alone. But initially, when we started the practice, letrozole was there in 2002 or those days. But in 2008, when letrozole was not available, we had to use clomiphene. But even then, there are some patients we cannot. We cannot use clomiphene routinely, and we have to go for other gonadotropin alone regime, which is practically very costly and not very effective. But now with the advent of letrozole, we have to use letrozole in PCOS patients. That doesn't mean for all ovulation induction we can use letrozole. There is a role for non-PCOS patient, clomiphene and letrozole. But hyperstimulation is more with and multiple follicle development is more with clomiphene. And that doesn't mean with letrozole we won't get hyperstimulation. With letrozole also we will get, but incidence is less. And in some patients, last 2 years, I've been trying that. If the patients with even with letrozole dose of 5 milligram, if they have hyperstimulation, we can go for an extended regime. That means from the second or third day, we use 2.5 milligram for 10 days. And then we can supplement with the gonadotropin. So the need of gonadotropin is less. No much effect to the endometrium. It is giving reasonably good result. I heard somewhere months back, somebody was trying even 5 milligram extended regime, but I will not use 5 milligram, use 2.5 milligram as extended regime for 10 days.
Combined with this metformin. So you recommend letrozole, it should be combined with the metformin, 1000 milligram, and
yes, definitely.
the starting dose should be 5 milligram.
I 5 milligram as starting dose. Especially, I do all the follicle scan monitoring. If you are not monitoring, definitely if we can give 2.5, but it's not recommended because we have, when you give ovarian stimulation, it is a must. We have to monitor because multiple pregnancy and can occur more commonly than IVF with routine ovarian stimulation.
Yeah,
And
quite
even with
right.
routine stimulation, we can go for an hyperstimulation syndrome also. So that is the two things we have to be careful. And metformin, I still use. Only thing is that patient tolerability is a little less. We have to slowly increase those from OD to BD to TID, not suddenly make it PID. And there are people are using with or without myoinositol, but my experience with myoinositol is less. I do still go for a metformin mostly, but there are a lot of people using myoinositol, reasonably good result, especially in patients who are not tolerating with the metformin. Myoinositol can be tried.
Thank you, Dr. Fessy, for excellent presentation. I think there are no questions in the chat box. Can we go to the next session then? Thank you.
Thank you, ma'am. Thank you so much. And now we have another wonderful session waiting ahead. And we have a teacher of teachers, Dr. Dipankar Banerjee. So I invite our esteemed chairpersons to introduce Dr. Nutan Agarwal to please introduce our speaker for the next session. And let me introduce our worthy chairperson, Dr. Nutan Agarwal, to the house. She is the founder secretary of Gynae Endocrine Society of India. At present, she's ex-professor, Department of OBGY, AIMS, New Delhi, and chairperson, head DNP program director. At present, she's in Artemis Hospital, Gurgaon. And she has 341 publications, 64 awarded 64 awarded Coron, 212 paper presented, 119 research, 290 faculty deliberations, and organized more than 40 conferences. We are really overwhelmed to have you with us, ma'am. Over to you to introduce the speaker for Dr. Sanjay.
Thank you, Dr. Seema, and thank you, Dr. Sonu, to invite me for this talk, for this chairperson, for this session. And I think I would like to invite the chairperson, the speaker, Dr. Pankaj Banerjee. Dr. Banerjee has got a special interest in the reproductive endocrinology since last 30 years. He's a director and IVF consultant, Ideal Fertility IVF Society, IVF, Jabalpur, and working in interventional sonography and endoscopy, fertility and prenatal diagnosis. He's a member of European Society of Human Reproduction and American Society of Reproductive Medicine, International Society of Ultrasound in Obstetrics and Gynae. Academic activities is running courses for the practicing doctors in fetal medicine, reproductive endocrinology throughout the year. And I would just like to say this topic he is going to deliver is a very pertinent topic, although to see looks very simple, ovarian reserve, but really it's a very catchy subject you have given, how much we have in the store. And then so many things, so many tests are being tried, but it's still none of the tests is, we say it's perfect, it's ideal, which can really diagnose that this is the one we can really predict the potentiality of having a pregnancy or IVF failure. And even now, this ovarian reserve is being related even to the reproductive failure in the form of recurrent pregnancy loss. So various tests are available. Let's see what doctor says, which is the latest one and how we should diagnose this problem. Dr. Pankaj Banerjee.
Again, thank you very much. And this topic, I have not brought any PowerPoint with me. I will be drawing some putting as in a classroom presentation. And my topic has been given the low AMH, how to handle it. It is very important to decide with the patient which low AMH you are going to do IVF. For low AMH, what I am doing here, I will be just describing what I am doing and getting pregnancies with low AMH. Basically, the low AMH is normally, I am not going into detail of Bologna criteria and position criteria and all, because it will be more boring if I go in detail. But basically, less than 1 or 0.9 or even 0.5 AMH, we call it low AMH. Whenever there is low AMH, we are scared whether we should do any IVF or even ovarian stimulation or not, or directly advise ovum donation. Every lady has a right to have her own baby, according to me, if she is menstruating. So most important thing is if she is menstruating, that means at least one egg is being produced. And baby can be produced by single egg in natural cycle. So we can make it also in IVF cycle also. But there should be a catch that we should have a very good communication with the couple, that what we are doing, we are trying to help you because we cannot change the playground. And if she wants that the baby of her own biological seed, then we should help them. The problem is how to go. What we do, previously we were doing all this DHEA and testosterone gel. DHEA needs a long 3 months therapy, which we don't have that time also sometimes. And if it doesn't give any response, then it will be a waste. But we try it. No, there is no doubt. Another is testosterone gel. We do testosterone gel. We use testosterone gel, but not very frequently. Then what we do? The most important thing is how we stimulate the cycle. I will be within 15-20 minutes, I will finish my talk and I will be touching what advanced things what we are doing in our clinic and getting pregnancies with low AMH. I am 35 with good AMH. These two groups I am not going to talk. These two groups we have to deal with because we are getting young females with 28 to 32 age with low AMH, and we are getting 35, more than 35 age with low AMH. This group responds well. This group responds little bit difficult. There are two groups which are very difficult to handle. That is premature ovarian insufficiency, which are with lesser age and with low AMH. Another group is with higher age with low AMH. What we do in low AMH with lesser age, usually patient not respond very well, but if we get 1 or 2 eggs, the eggs are usually of good quality.
Right.
But mind it, here what we are doing, we are going for even 1 follicle also. That is, there should be a very good communication with the couple. With the higher age group, with low AMH, patient comes with 0.5, 0.05, 0.04, but the main criteria is that she should be regularly menstruating. Patient with endometriosis, patient with normal normal ovarian insufficiency in later age, more than 35, 40. Most of the time, I am using double stimulation protocol. The double stimulation protocol is not exactly Shanghai protocol. We have devised and we do a luteal phase stimulation also. My intention of treating these patients are, whatever your age, it will grow up. If you can retrieve eggs and make embryos and freeze them in 2-3 cycle or even in 1 cycle, even luteal phase cycle also, we can get good blastocysts and we can transfer them later on in frozen embryo transfer. Then how to start? That is very, very important. Any patient which is low AMH with lesser age also, the day 2 ultrasound and day 2 hormonal milieu, hormonal investigation is very, very important. I always do FSH, LH, estradiol and progesterone. The progesterone should not be more than 1. I more prefer less than 1 because if it is more than 1 or more than 1.5, then if you are stimulating there, you are rescuing the previous corpus luteum. Then why we should not use OCPs to make more secure? Any sort of down regulation by OCP or by GnRH analog for longer duration suppresses the ovary. I want to use the natural cycle with natural FSH and LH drive in patient. So what to start, how to start on second day. On day 2, I have to do assessment plus if estradiol is less than 50 to 60 picogram per ml, that means even though there might be some cystic area in ovary and D2 scan, it is not active. So we can go for stimulation. If the progesterone is less than 1, then previous corpus luteum is not active. That means you are negating two things, that is previous functional ovarian cyst, which very commonly happens in later age. If she is menstruating and she is having a corpus luteum, then corpus luteum, if rescued in your protocol, then you can do the stimulation, but you cannot transfer it as we do in luteal phase ovarian stimulation, because there is already progesterone is high. Now the thing is why we are doing LH and FSH. If there is LH is more than 10, then activity of LH will hamper your stimulation. Now, if this happens, better to use a simple way, that is use 1 month oral contraceptive pill. But if things are within limits, then you can start with the gonadotropin. In my center, I am only using GnRH antagonist protocol. I am not using minimal stimulation nowadays, because previously it was thought the lesser eggs, better quality, but gradually what we have seen that we should have more eggs as far as possible. There are methods to calculate how much should be the gonadotropin dose according to age, the body mass index, and the AMH level. With that, we can estimate the dose, what to be done. Now, there are two ways of treating the patient. I am basically a pro HMG person. So I try to do HMG from the beginning. I start HMG from the beginning. But a good quality recombinant FSH gives better results, good quality eggs. So there is a possibility and use of recombinant FSH like Gonal-F of 300 for 6 to 7 days. But start the cetrorelix antagonist very carefully, because these people, they have abnormal follicular phase because they are having abnormal endocrine milieu. So there should be no premature LH surge, has to be prevented. So cetrorelix should be started very carefully by doing an ultrasound. Whenever we start cetrorelix in the later part of the follicular phase, we do an ultrasound and then see how many follicles are growing. If he gets 2 or 3 more than 17 millimeters follicle, I always do estradiol and progesterone with LH. Because if LH is raised, then you will be having trouble in getting good M2 oocytes. So to prevent it, cetrorelix is there. Suppose there is rise in LH, it should be less than 2.5. If it is rising towards 10, double the dose of cetrorelix. That means if you are using 250 microgram, that is 0.25 milligram, make it twice a day. Whenever there is a rise in LH, it will create problem in getting good quality eggs. If progesterone is less than 1, then you can do a fresh embryo transfer. If progesterone is more than 1.5, this happens in this age group very, very frequently. Then don't do the embryo transfer, freeze it. If I am doing a single stimulation, I always try to ask the patient to go for double stimulation in luteal phase also, so that in one cycle you can get more eggs and more blastocysts. We freeze those blastocysts and then we do frozen embryo transfer. This is the usual way what we are following in our clinic. It has to have a very good control over the menstrual, this follicular phase. And whenever we are transferring the embryo, we usually nowadays don't believe in vaginal progesterones, because I don't know whether they are taking it normally or not. So I will, if I do a frozen embryo transfer, I always give injections of progesterone, which is subcutaneous 50 milligram per day. I frequently do post embryo transfer estrogen and progesterone assessment so that the luteal phase should be supported well. This gives a hold on the luteal phase also and gives a better pregnancy rate. Now, if the patient is having not allowing or not comfortable with the double stimulation, because double stimulation is little bit uncomfortable for the patient, because you have to put a lot of injection throughout the month. So we can do a consecutive stimulation also. But main purpose is try to take as more as eggs, make the embryos, because we are not very much comfortable with egg freezing. We are very much comfortable with embryo freezing and blastocyst freezing. So we collect the blastocyst and then we transfer them in frozen embryo transfer cycle in later on. This is the normal way what I am doing. Now, if patient is, we are getting, every one of us getting a lot of patients in later part of the age losing their, I get a lot of patients losing their adolescent child by some accident or something happens, and they are 41, 42, 43 having, now they want to have their own child with their own eggs, but they are a little bit old. So I give an offer of ovarian rejuvenation also. Ovarian rejuvenation is, I cannot write it or explain it, but it is a breaking the hyposignaling in body. That is, whenever you disturb the normal anatomy of, it is just like pruning the tree. If you prune the tree, you will get good branches. So if you can prune the ovary also, then there might be a regeneration of the stem cells in the ovary. So what we do laparoscopically or transvaginally, most of the time laparoscopically, and with that making platelet-rich plasma in my clinic and then inject it inside the ovary and make ovary little bit, make little more punctures over there, so that there should be a, but again, I am telling you, these are all desperate method to get eggs. Another what is going on, what we are not doing, but we tried it also, to supplement cytoplasm from young eggs so that some of the mitochondria can go to the old eggs. But again, this is also a very difficult procedure, as my wife is my embryologist, daughter is an embryologist. So they are, I tried them, they tried it, but the pressure in the ovary goes up. Sometimes it bursts. Sometimes it creates disturbance in fertilization also. But we tried it and we will try it again with the consent of the patient, because the mitochondria from some other lady, you are not doing egg donation, you are not doing the genetic of other lady, but the genetic material of the female and her husband will be used, but there will be a mitochondria gene from some other lady. So there will be a mixing of mitochondria, because mitochondria is a powerhouse. So it gives a better M2 sites, or it will give a good chromosomal segregation. These things what we are doing in our clinic, and I think whatever I have to write, I have already told you, and this is the way I want to talk. And thank you very much for patient listening.
Thank you, sir. It was so enthralling, and you're the best. So I will request Dr. Vijay Lakshmi to thank sir and conclude this session. And Dr. Vijay Lakshmi, she is the professor. Dr. Vijay Lakshmi is fellow in reproductive medicine, Chennai. She is specialist in laparoscopy and hysteroscopy, and she has special diploma in ART, and her special interest is ultrasound and color Doppler in infertility. And she has a publication on premenstrual syndrome, familial tendency to endometriosis, and many more. So over to you, Dr. Vijay Lakshmi.
Thank you, ma'am. Sir, it is a very excellent session in poor ovarian reserve. So many methods, dual stimulation and ovarian rejuvenation. Nowadays, burning issue, even with the young people, young ladies with poor ovarian reserve, AMH, not even one. How to stimulate and how to retrieve more eggs and how to make embryos and how to give better chances for pregnancy. So much elaboration. And in ovarian rejuvenation, what are the complications, sir? And thing I want to know. And one more thing, Instead of Bologna criteria, nowadays we are using Poseidon classification. So you elaborated so many things in your lecture, sir. Thank you once again for such a elaborate information for treating poor ovarian reserve patients, and thought everything in your protocol, antagonist protocol, how to choose and how to increase the dose. These are the things very important to prevent premature LH surge and increase in progesterone levels, also how to assess. Thank you very much, sir, once again for your elaborate session. Thank you, ma'am.
Dr. Banerjee, it was really excellent talk, and it was, you are actually a designer IVF specialist, I should say. It's a very well designed different method. And one thing I just want to give a message that AMH, many times I have seen that they come with a low report, and we don't take the history what all drugs patient has taken. Because I have seen in my practice that when they take Dydrogesterone and certain drug like OC pills, their AMH goes down for the transient period of 6 and even I have done this work on this also, and it goes down for 6 months or so. So just to offer them immediately donor oocyte is not a good option. So you are very rightly said that even if AMH is low, you should try to give them a chance to have their own genetic baby. So that way, I want to message that AMH low, just if they are taking some drugs, always rule out. Yes. That whether it is a transient low of AMH, because in the young age, so many patients are getting drugs, something or other. So always try to avoid that whether it is because of some drugs, and then give them time and then check.
In some cases, madam, I observed if there is any ovarian cyst or something from rural people, they are going to some other doctors. They will resect the ovary.
Yeah.
This is also one of the cause for low AMH.
Yeah. But Dydrogesterone, I've done a work. Dydrogesterone causes low AMH, and it is just for transient period for 3 to 6 months. So you should be aware of that fact. So suppose somebody advised donor oocyte, I have seen, because many young IVF specialists, they just advise donor oocyte without checking anything. So that is very
for ectopic pregnancy also, sometimes they will do salpingo-oophorectomy.
Yeah. And then it may fall for some time. That is another issue. Yes.
Yeah.
Yeah.
There is one question also, Dr. Nutan, if Dr. Banerjee, you can that what should be the cutoff of E2 and progesterone post ET, like in the luteal phase, someone is asking.
I think we have this question, Dr. Sonu, with us in the panel. And sir, please stay with us to answer that question, or you can answer right now also, no problem.
You see, I will suggest that the cutoff which we should keep, if you keep 1 for AMH, 10 for FSH, 100 for estradiol. If you remember this like this, it may be much easier.
How much?
That otherwise, AMH 1, it is multiplied by 10. FSH anytime more than 10, and estradiol anytime more than 100. There shows the poor reserve.
So we take up the question. I think Dr. Sonu, we can take up the question from the panel, and Dr. Vijayalakshmi, we have to tell the audience that she is Professor Narayana Medical College, Nellore, and infertility consultant. Dr. Vijayalakshmi, I missed this part in your intro. Thank you so much. And Dipankar sir, you will be there for question answers with us, no, sir?
Yes.
Dipankar sir.
No problem.
Yes. So we will start with our question with our panelists who are charismatic.
Ma'am, there is a 1 minute break over here.
Yes.
If you allow me, ma'am,
Okay,
there is a 1 minute break over here.
Yes, Deepika ji.
Jagsonpal Pharmaceuticals Ltd proudly presents PRORETRO micronized dydrogesterone tablet 10 mg. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for PRORETRO.
Good evening to all esteemed faculty and attending doctors. From Naari division of Jagsonpal, I am Vijay Kumar, Zonal Sales Manager North, and we look forward to your support for PRORETRO for luteal phase support in ART, recurrent pregnancy loss, and threatened abortion. We thank you for this opportunity to connect with you all today through this webinar, and are proud to present PRORETRO 10 mg tablet of micronized Dydrogesterone. API of which Jagsonpal is manufacturing now. After years of R&D, Jagsonpal makes all the quality API of dydrogesterone with the intermediates making India Atmanirbhar for producing this critical API. The quality of our brand PRORETRO 10 mg is backed by a bioequivalence study to prove its clinical efficacy and safety. Moreover, doctor, with the clinical advantage, PRORETRO is assisting motherhood, delivering happiness. Our indigenous API is available with remarkable reduction in cost of the patient, providing a more economical therapy at just ₹50 per tablet. PRORETRO is readily available at all the counters near to the prescribed. Our sales team visiting you is continuously striving to make your bulk purchase experience effortless and worthwhile. Looking forward to your support to our newest brand in our portfolio, that is PRORETRO. We also present Endoreg, that is a Dydrogest 2 mg tablet for medical management of suspected and confirmed cases of endometriosis associated with pelvic pain. Enhance her fertility with Cystilia M, the right combination of myo install and D-Chiro install in 40:1 ratio to restore ovulation and restore productive health. Thank you. This is all from my side. Thank you for patiently listening.
Thank you very much. Ma'am, we continue with the panel
Yes,
now.
exactly. Yeah, we will ask the panel questions, and Dr. Sonu, if there are any questions left, we can take in the end. Dr. Anupam Bahadur is now joining with us. Then we have Dr. Raja Priya, the Managing Director, Srinivas Priya Hospital. She is Secretary Peramburu IMA Women Wing, and she is Secretary IFS Tamil Nadu Chapter. Our next panelist for the panel are Dr. Anupam Gupta. She is a Senior Consultant at Jindal IVF Center. She is Secretary Greater Chandigarh Chapter IFS, and she is faculty in various regional and national conferences. Thank you, Dr. Anupam, for being with us. And we have our versatile Dr. Sonu Ahlawat, our very own Haryana Chapter Secretary. She is the in charge and Unity Head Reproductive Medicine, Artemis Hospital, Gurgaon. And we have Dipankar Banerjee sir joining us, and Dr. Rekha is not here, she's gone for marriage. So we have our wonderful panelists who will be answering all our questions amicably, and the final verdict will come from Dipankar sir. So can we have the first question, Deepika ji? This question goes to Dr. Anupam, Dr. Priya. So what is the pre-stimulation management a beginner should do in ovulation induction? I think most of it has been discussed already. So if you want to add anything to it, Dr. Raja Priya, we will be really happy.
Yeah, see, like I think whenever the first time we decide to induce ovulation, we have to first understand the profile of the patient, her age, her ovarian reserve, her cycles, and the best way to assess the ovarian reserve is a basal scan for a beginner, and because we get a good idea day 1 to day 3 how the antral follicle count is. And then it is great if the same person who's doing the ovulation induction does the follicle tract, because they get a tremendous input on the growth of the follicle, the endometrial pattern, thereby we can judge the quality of the follicle. And during the pre-stimulation, we need to understand to get the maximum, what is it you're going to do? Is it a natural cycle, sexual intercourse way of treating her to help her become pregnant, or are you programming her for insemination, wherein you would like more than that one follicle? No, you would like to have somewhere between 1 to 3 follicles, or are you going in for further treatment, like whether you're attempting ICSI or IVF? So I guess the pre-stimulation is based on the purpose and on the type of responder you're dealing with.
Very nicely elaborated, Dr. Rajapriya. So it is mandatory that you, whenever it is semen analysis, it is better to have a look into the microscope yourself. Same way, if you are doing ovulation stimulation, then it's better to have an ultrasound and then proceed. So, sir, Dipankar sir, you would like to add anything to it?
It is a simple thing that whenever we go for either IVF or stimulation for IUI, whatever it is, the assessment cycle should be very good. Because I do assessment cycle in a very elaborate manner. Otherwise, what will be your plan? The planning will be very good if you assess the thing what you are going to do. So there are a lot of things, I don't want to detail it, but definitely what has been told, that usually the basic thing we should do.
Okay, sir. Next question is to doctors. Hello, this question is to Dr. Anupam. Dr. Anupam, are you satisfied with AMH as diagnostic criteria for poor ovarian reserve or PCOD or overstimulation?
Yes, AMH is a very good diagnostic criteria combined with AFC, age, and BMI. So these points have to be taken into consideration when we are trying to individualize the dose for ovarian stimulation. Alone, we should not rely alone on AMH as a diagnostic criteria.
So what is the cutoff you are taking at your center for AMH?
It should be taken in conjunction with AFC also.
No, when you decide for a donor oocyte, then what is the cutoff AMH that you tell your patient that this is the bad AMH? Like now, after listening about the regenerating ovaries, I think we all are not justifying in getting a donor. So what is your take on that? What is the cutoff set at your center?
We have had pregnancies even with AMH as low as 0.2 milligram. But if the patient is young, even with low AMH, you can have very good pregnancies, as Dr. Banerjee said. But if the age is more like about 40, then with low AMH, you have reservations. But still, if you can see the AFC on ultrasound, then you can go ahead and at least give one chance to the patient to stimulate her ovaries.
So what is the donor selection criteria at your center? You can just share your experience. I mean, there are no two thoughts about it.
Like we ask the patient if she has limited resources and can just afford one cycle of IVF, and the AMH and the age is not on her side, the AMH is very low, her age is more, and she has very limited resources, then, and she wants the maximum results, then we ask her to go in for donor oocytes. But if she wants to have at least one try with her own eggs, then we advise her to go in for self oocytes, even if the AMH is low.
Very true. Very
Seema, I would like to add something here, that if this is the, like with low AMH and AFC and age, I would also like to do a baseline FSH. If it is like less than 12, then maybe the chances are better for the patient, and I would like to go in for her own stimulation rather than for a donor. But if FSH is high, then maybe we can counsel her for a donor.
Is E2 also, are you considering, Dr. Sonu?
Not exactly. E2, like if we are doing a scan, so E2, usually I don't get that done, but FSH and AMH and AFC.
If I can add a point here, see, your question is primarily asking, are you satisfied with AMH as a diagnostic criteria? In the first place, slowly, we are not doing AMH as one of the frontline tests. It's kept as a test when you bring in, only if you're suspecting that the basal scan is showing a low FSH count, because straight away doing AMH as a diagnostic tool sometimes gets the clinician a bit jittery, and if the patient starts Google searching, it puts their morale down. And as Sir was enlightening us, if the ovary is showing follicles, her cycles are good, we don't have to bring in AMH as a frontline diagnostic criteria.
But we have to counsel her regarding her prospects of fertility. We're seeing the AMH and AFC.
Yeah, I think everybody is correct in their place. Dr. Dipankar sir, you want to add, because E2, I mean, it's much talked about, but as we all feel that it may not help us. So Dipankar sir, we need your inputs.
See, Seema, what we are doing private practice, and we are responsible for giving the service. And whatever things we are going to handle, the patient should know that how much difficult you are. Otherwise, there is no point that why I should not know the AMH and why she should not know the AMH, because I should have a good communication that, see, this is your AMH, and they already, most of the time they Googled it and they know what is AMH. But my point of practice view is that the couple who is coming to me should be informed everything, why I should take their stress on me alone. You should also take. Because we are going to help you. And there should be a communication, a counseling that if this is the AMH and if you want to have your own baby with your own biological seed, then we can help you by going the limit we can go. So usually the couple, they get convinced, and we are still, by God's grace, quite comfortable with this. But definitely I do AMH with every patient, and with day 2, what I have said, that I do all these tests to make myself comfortable with patient and with the stimulation protocol also.
Sir, how much weightage you give to E2?
See, E2 is the one of the very important. If you are doing FSH also, if you do alone FSH and don't do E2, then there will be a false positive or false negative. There will be a problem. So you have to correlate with the E2 and FSH, and especially in AMH, low AMH cases, the follicular dysfunction of a previous cycle is very common. And if there is a pre-existing estrogen producing cyst, follicular functional cyst, it will create problem in your stimulation. So try to be as far as possible, because you are going to put too much effort and money. So as far as possible, start with a good runway, then you can take a flight. Otherwise, there might be a problem when the takeoff is there.
Yeah, there is too much variability in the cycle. So maybe high E2 may suppress the FSH and we may get a wrong.
Very true. So how many times do you need to in the cycle, and what are the value you are taking? Can you just elaborate briefly? Day 2, day 14, day of pickup, if you're doing, and you said after transfer you're doing, so what are the values you're taking into consideration?
Usually the day 2 FSH should be less than 30 to 6, maximum 50 to 60 picogram per ml. It should be. If it is less than that, you are comfortable that she has been withdrawal with the previous cycle. So she is having a good menstrual flow, and this is the withdrawal, clear withdrawal, and there will be a better selection of the cohort which we are going to stimulate. So I always do this, because if I don't do this, then I cannot make myself whether I'm doing it correct or not. Second, if we want to do in between day 7 or day 8 estradiol, I do most of the time, whether it correlates with the follicle or not. And definitely at the time of stimulation on the day of HCG, I usually do E2, E4 and LH, which gives me a good hold over the trigger. Now, if the estrogen is less, what I suggest that better to give more amount of HCG injection, not 10,000, go for 15,000. I do that because there are reduction in follicular blood flow in more age group, higher age group. So there is a paper that if you go with a higher amount of HCG, you might get the smaller follicle also, you might get M2 sites. Because you have noticed that when we do ovum pickup, there might be 3 or 4 follicles are there, but your embryologist get 1 or 2 site. So there is a desperate attempt to get as many as oocyte, and that should be more of M2. Otherwise, getting GV oocyte or M1 oocyte of no use.
Right, sir. So next question is to Dr. Sonu. Dr. Sonu, does increasing the dose of HMG more than 300 milligram help the patients with poor ovarian reserve?
I usually don't go beyond 300, and there are papers and studies that giving more of HMG is not of much use to these patients also.
And what is your starting dose? Do you always start with 300 in poor reserve, or you start with lower dose also and get results?
No, I usually start with 225 or 300. But 300 is the usual dose for patients with low ovarian reserve.
Okay,
I will do the mild stimulation protocol.
Dr. Seema, may I ask one thing?
Yes,
is
please.
it allowed?
Yes,
no,
ma'am.
I was asking that AMH we always correlating with the poor reserve as a quantity wise, but the quality wise also it is very important. And I will never agree with the fact that AMH should not be done. It should be done always in these patients. Second thing I say that, you see, I have seen in my practice that 0.2 was the AMH, and with which she conceived, and then it came out monosomy 17, monosomy chromosome 17. So this is what Dr. Dipankaran says that regarding the AMH low value, regarding the failure because of the abnormal oocyte. So you have to counsel for that you may conceive. Still, there may be problem to the conception, chromosomal problem.
But ma'am, that may be correlating with the age. If she's of the lower age group, then I don't think
she was 30. She was 34, 35. That
yes.
Patient. And
age has a very important role in this case. If the age is less than 35.
No, younger patient also can have this problem if their oocytes quality is poor. Second thing, even patients have been gone to the court with the no TSH done in the IVF, that TSH was high, later on came to know, and she said, I spent so much money and TSH is not done in my case. So
We do
AMH, I
it.
think, should be done for all the patients. There is
Right,
very important to do all the tests.
Right. So we skip next question, question 4. We go to 5th question to Dr. Rajapriya. Next, skip this question, Deepika ji. So we go to next question. Is diminished ovarian function always is it associated with lower androgen levels also, Dr. Priya? Are you doing androgen levels also in poor patients?
No, I do not do. See, the diminished functional ovarian reserve, like it's a situation where we come to see that the AMH is low and the AFC is low, or you have seen over observing the cycles, it's not happening. It depends on what kind of a patient you're dealing with. If you're dealing with a PCOD patient, then we do understand that intra-ovarian, there may be a mismatch of the androgen and estrogen level. Even in that case, it is not my practice to assess the serum androgen level. I do not believe in jumping too much of doing this hormonal profile. It confuses the patient also, and it all the more confuses us. But it is an assumption that probably in a poor ovarian reserve patient that the low androgen level may play a role. So I guess the patient profile would decide that, but I do not have the habit of assessing the serum androgen level. I would like to hear the other panelists' opinion.
Right. Dr. Sir, Dipankar sir, do you recommend? Actually, I think none of us are doing this levels for IVF patients. But sir, what is your take on that?
I don't do until unless it is indicated, I don't.
Right, sir. So we go to next question. Next question is to Dr. Anupam. What percentage of poor ovarian reserve patients come to you out of all your IVF patients, Dr. Anupam?
We don't do serum androgen levels in poor ovarian reserve patients.
I think none of us is doing. That's what we go to next question now. Deepika ji, we just want next question. Dr. Anupam, how many patients you come across? What percentage of your patients have poor ovarian reserve, regardless of age, if we talk?
About 25 to 30% of patients are poor ovarian reserve because of because of late marriage, and patients are more career oriented. They keep on delaying childbearing, and so when they come, ovaries are already depleted of follicles. So the percentage of poor ovarian reserve patients is quite high, about 25 to 30%.
And what is the ovulation induction protocol that you're following at your center for them?
We give a mixture of recombinant FSH, LH, and HMG in these patients, like about 150 of recombinant FSH, 75 units of LH, and 150 units of HMG.
So you're giving LH separately?
And in an antagonist protocol.
No, so you're giving LH separately to these patients?
Yes, 75 units of LH, because what we have seen that if the age is more than 35, or if there is poor ovarian reserve, the response comes out very well if we give them LH, recombinant LH plus.
LH has got such a short life and it has not been recommended. Dipankar sir, I need your inputs on this answer.
I don't use recombinant LH, but whenever we use recombinant FSH for first part of the follicular phase, then personally I always use HMG in the later part of the phase, 2 to 3 days.
Right, so Dr. Sonu, Dr. Rajapriya, are you using LH? Because what I have gone through literature, that recombinant LH is not of much use and it has got very short life and it is very expensive also. So what is your take on that, Dr. Sonu and Dr. Priya?
I do not use this particular one, but I think Merck is coming out and pushing a product of a combination of recombinant LH with recombinant FSH recently into the market. I have limited experience.
Can I interrupt?
Please.
Yes, sir. You can. He's always.
This LH theory is most of the time what fairing people are doing is, if you use a micro dose of HCG with FSH, then it works very well, rather with even better than recombinant LH. So most of the time what we are using HMG nowadays.
Very true, sir. Yes.
Exactly, sir. That's what I was about to say, because I use mostly Menopure, like highly purified HMG for these kind of patients from the starting. I rarely use recombinant.
Right. So next question we have to Dr. Sonu. Dr. Sonu, Actually, it's a answer is very obvious, but do you find any difference between recombinant and urinary gonadotropin?
No,
The
no.
concern.
Sorry, Seema, can you please repeat it? I was not able to.
Actually, everybody is using recombinant, I feel. But when we use urinary also for our patients, and I have seen that most of the results are like almost same. So what is the advantage? Are you using recombinant only or urinary also? And do you find any difference between the two?
I usually, like since the last 4 or 5 years, I've been using urinary gonadotrophins. Like I said just now, highly purified HMG. And recombinant, I don't use for these poor ovarian reserve patients. And because of the small element of HCG and even Letros, I have not found very much of any advantage in using them. And
or any advantage of like literature says somewhere, yet urinary and recombinant you use and they give very good results. So I think the Pankar sir must have tried. So can you share your experience?
Basically, Seema, I'm a pro HMG person, and things are very simple. That all HMGs from different companies are usually not same. You have to choose which is better, and very important, keep the HMG whenever you are putting in a fridge. Keep it in UPS because cold chain is very important. Otherwise, sometimes this happens. I have faced that also. But a good urinary gonadotropin HMG gives very good result, very good blastocyst and good number of oocyte. Definitely, recombinant FSH is a good tool to have a consistent standard method of treatment. And we have to choose accordingly whatever we are doing with the patient.
This is called life simplified. So all with HMG, sir. Next question, dual trigger. I think Dr. Fessy has talked in detail and we all are very clear. So we skip next question, Deepika ji. So and next question is to Dr. Priya. Is it freeze all for agonist trigger? How does luteal support differ in these patients?
So I usually use a HCG trigger, right?
Okay.
And I am pro, like whenever possible, do a fresh transfer. However, when we are dealing with a PCOS patient, only in the situation a high responder, the choice becoming the agonist trigger for me. So I suspect she's prone for OHSS, then I go for an agonist trigger. In that case, there is always a modified luteal support which I can use. It is not necessary to do a freeze-all. So if I know the cycle is going good, the lining is appearing good, then I do not, or if I land up with very less embryos, then I may decide for a fresh transfer. But however, the luteal support would be a little different, that I add in my estrogen, progesterone, and I also bring in my HCG trigger, HCG injection. So it is not a freeze-all policy for me, depending on the OHS's risk.
Fine, I think this also we discussed in detail. So I put my next question to Dr. Anupam. Dr. Anupam, what is the cutoff for progesterone level which will indicate trigger failure? Though we have discussed almost. So what should be the level on day of transfer, progesterone level? What do you take?
Like if the progesterone level is more than 1.5, that it indicates premature luteinization. And so here we may have to freeze all the oocytes and go in for a frozen embryo transfer.
So Dipankar sir, what is the cutoff? 2.5, I think, sir. Dipankar sir.
Cutoff level of progesterone level which will predict trigger failure.
I mean, not exactly that we may not get good oocytes. Poor pregnancy. Yes.
See, progesterone is nowadays used as in place of GnRH and agonist to down-regulate the cycle if you can do a good freezing. It is a cheaper way of using with not having premature LH surge even by using the progesterone from the beginning of the cycle. So trigger is not a problem even though the progesterone is high, but if I do a trigger with high progesterone like in luteal phase also, in luteal phase, I always use medroxyprogesterone along with stimulation, because if you use luteal phase, then there will be a period in between. I don't want that. So if there is a progesterone and I have to do a trigger, then I do a trigger and then do the freezing. But I have one question, because I seen that there is dydrogesterone from the company which we are sponsoring, Dr. Deepika. The dydrogesterone when we use, then in luteal phase, then how we do the progesterone estimation in luteal phase, because dydrogesterone is not progesterone. If you can give me an answer later on, no problem.
Here I would like to add something that I was going through a paper from China. They have taken 2 as the cutoff, and if the progesterone was more than 2, it was detrimental to the oocyte also.
Yes.
So it had negative effect on the quality of the oocyte, as well as we know on the endometrium environment. But even the quality of the oocyte, they were saying it like it had said that it is not good.
Right. So what is the limit you are taking? Because most of the literature says 2.5 is the upper limit. If it is more than 2, the quality will be bad. So Dipankar said, do you do that estimation on pickup day? And
I don't do on pickup day. I do on HCG day.
Trigger day.
Yes.
Yes, it has to be done on the trigger day, but the levels are pulsatile. It said that the levels of progesterone are pulsatile and they may vary from time to time. So
Yes,
should not rely much on that.
Yes.
So I am also not doing it, but if we are doing a freeze-all cycle, then I'm not doing it at all.
Because the all hormones in the body in female are all in waves. So we have to do all tests with interval test, but frankly speaking, practically I am not doing, I do only one test. If it is more than 1.5, then I have to think about whether to go for the
stimulation. Right, sir. So next question, and this will be the last question to Dr. Sonu. Dr. Sonu, empty follicle syndrome, you tell us something about empty follicle syndrome, what is to be done, and what is the role of LH estimation on day of trigger?
Seema, this is a very question which is empty follicle is like we dread that most of the time. So I don't do LH estimation. I usually, like, if we've had this, so I give a dual trigger the next time. But role of maybe Dr. Dipankar, he would be able to tell much better.
Sir, please tell us this.
Empty follicle syndrome, something happened with the patient with the injection. Because
exactly.
Is it always the patient? Because it has happened.
I just did, I put it in my case history also, case testimonial also. The patient has come next day within 12 hours for ovum pickup. So I did one side and no eggs. Then I stopped. Then I asked them, they said they just 12 hours prior there. Then again, next day, I did pick up, I got eggs, and by God's grace, pregnancy also. So empty follicle syndrome is, we are doing either the HCG is not good, or they have not put the things correctly, or the timing is not correct. And
So
one thing is very important. When we give LH trigger, like GnRH trigger, if you are using some new brand, always try to do next day, 24 hours, the LH estimation, because if it is not giving a good LH trigger, then you might not get good eggs next day.
So I have always made it a point not to write 12 o'clock at midnight. So I usually write 11:50 or 11:55, because then the patient thinks the date usually changes. So that's why I always make it a point that I write it 11:55 or something.
My anesthetist always creates problem. They come on 12:30.
But sir, the LH estimation is done at 10 hours or 24 hours, like you were.
The next day you are going to meet the patient. So it is better that you should have after 12 hours, you should do a LH estimation at least.
Yeah. So what do you take the cutoff as 10 or something? 10.
10.
So if it is less than 10, a second trigger is given.
Second trigger with HCG, no LH.
And it is usually the pickup is done at the same time, or you extend the.
Extend.
Extend by 12 hours. So, sir, I think I have done with
I have one question. What do all the panelists have to say about a dual trigger in normal responders and in poor responders? So how many are doing it? Because I am not doing it, so I have.
I am doing it very frequently, and we get very good results. The number of M2 oocytes is very good. The fertilization rate is very good with dual trigger. I am doing it usually in normal responders and in poor responders.
It needs lots of counseling actually, which we are not able to do probably. So we are not doing it, but we will start doing it now.
Looks like it is becoming an attractive option for the future, because when you know a previous cycle has failed and you are tempted to do something extra, you feel that dual trigger will soon start coming, because it is attacking the whole physiology in all ways. No, you're getting the HCG also in, and you're getting the GnRH.
So in that case, freeze-all is done, or you transfer in the same cycle, Dr. Rajapriya?
We can transfer in the same cycle also.
If you're not having a risk of OHSS, you just do a modified luteal support and you can do a fresh transfer.
No, I'm talking about poor responders, not hyper responders.
Poor responder, all the more, no? If you have very few number of embryos,
yes,
all the more warrants the transfer.
No, but we can give the routine luteal support in case of dual trigger. We need not give the aggressive luteal support because HCG has already been given.
Yes. With agonist, it is dual trigger always. I mean, it gives good results. So I think we have
one thing I would like to add: if the patient gives history of poor oocyte retrieval in previous cycle or empty follicle syndrome in the previous cycle, then this dual trigger works very well in those cases.
Right. Very true. So we have some questions from audience, sir. I think another 1 minute we can finish. Somebody, Dr. Pallavi wants to know that endometriosis affects maturity of oocytes. What precautions we should take? So we can have the answer in one line, Dr. Dipankar, sir.
What was the question?
Does endometriosis affect maturity of oocytes?
100%.
What precautions we should take? What precautions to be taken, sir?
What precaution? Stimulate as much as possible. Try to do stimulation as much as possible, and don't enter into the chocolate system.
Very right, sir. And
there's one more question, Seema. So somebody, Dr. Yogita, wanted to know the E2 and progesterone level post embryo transfer. And I would like to know, sir, what day do you do it, day 3 or day 5? And what do you take as the cutoff?
2 days after embryo transfer most of the time, or if patient doesn't come after 2 days, then on the day of embryo transfer, E2, P4, 20 and 200. Simple.
Okay. Because I usually do on day 5 and I take it as 25. So
याद करने में easy है ना.
Or questions here, you can take, Dr. Sonu. If there are more questions from audience, please take.
There was one more question. Why agonist protocol fading in poor responders if AMH more than 3 and age less than? I think we have discussed. So I don't think that any of our panelists, Dr. Rajapriya, Dr. Anupam, if you would like to ask something or you want to give a comment, Dr. Dipankar.
Management of severe OHSS, Dr. Alia Tabassum has asked. Actually, severe OHSS
That's not in the topic, Seema. So
I know. It will be freeze-all. It will be freeze-all and
agonist trigger with freeze-all.
Yes. So, do we have any questions or we conclude? I think we.
Thank you so much, Dr. Dipankar.
I think we are done with all the questions now. Any experience with the use of testosterone, pre-treatment testosterone gel?
I think sir has used, yes.
Yes. See, there are evidences that you can use a testosterone gel. Now there are testosterone gel easily available, and we should use it at least for 21 days prior to doing this pickup, this stimulation. And if you are using DHEA, do it for 3 months prior, then do it. So there is a rationale that you are in delta 4-5 pathway, you are increasing the amount of the DHEA and testosterone. So there will be more aromatization and there will be more estradiol, better oocyte quality. This is the basic rationale. But anybody of us, if patient comes to me for assessment cycle and for IVF in next cycle, utna time nahi rehta.
Yeah, very right. We don't want to waste time in doing these things. No?
Exactly.
So thank you, everyone. It was such a wonderful session. Thank you, Dipankar sir. Thank you, Dr. Fessy. Thank you, Dr. Anita Khan, Dr. Savita ma'am, Dr. Vijay, Dr. Nutan ma'am. Very important inputs we got from her. And The excellent
मेरा-
inputs from Dr.
मेरा-
Raja Priya.
मेरा
Yes.
सीमा एक प्रैक्टिस करने वालों का एक मैसेज मैं ये देना चाहता हूँ कि you are going to help that woman. Don't try to be afraid of low
Right.
AMH that what they will say. You are trying to help them.
Very
If
right,
they get
sir.
a baby with their own seed, they will be very, very happy because egg donation is a very drastic and very, what I feel as a male that
Exactly. Even if it is the AMH is 0.1 or 0.2,
even
I
if
always
he is-
give
if
I
he is
always
mis-
give one cycle of stimulation and
I did 2-3 natural IVF cycle with low AMH, only watching and जैसे making a कि कब oocyte निकालना है, केवल HCG का इंजेक्शन देंगे. So this happens. So ज़्यादा से ज़्यादा क्या होगा? You will not get any eggs. You can abandon the cycle. But if you can get, then it will be a very good help to the lady because they are very much stressed because everywhere they go, go for egg donation. Egg donation, if I do a sperm donation for me, then same thing happens with the girl also.
Yeah, I put myself in their place because I would not accept a donor egg. So usually I do for them whatever AMH they come with.
I should not say like this, but this happens in my mind and this goes in my mind. So I do that in that.
We appreciate your emotions, sir. And I think we should be more honest and more clear to our patients. That is the message we get from you. And that saves us from many problems also. And we really thank Dr. Raja Priya. It was really pleasure knowing her and getting inputs from her. And Dr. Anupam and our much sorted Dr. Sonu Balhara, our secretary, and Dr. Deepika, not to miss, the team Jagsonpal. Thank you for all the efforts. And I think together we've learned so much from each other and hope to have many more meetings in future. Thank you, everyone. Dr. Sonu, if you have to say anything, you're most welcome. And Dr. Sanu from Nepal,
bye-bye.
she has attended all our sessions. Dr. Sanu is there, she can join us. And Dr. Sonu, you can speak on behalf of our.
Yeah, thank you so much, Dr. Anupam, Dr. Raja Priya, and Dr. Nutan ma'am, Dr. Vijayalakshmi, and Dr. Deepika. You are really a support for everything on every panel and every academic front. Thank you so much, everyone. Yes,
Thank
Raja
you.
Priya.
Thank you. Bye.
Beautifully.
It was a very nice panel and we really enjoyed.
Again and again for those questions, we can think more and more because each one of us have a different experience
Exactly.
and challenge. So these questions, we can hold yet another panel.
Yeah, we can have a full panel for an hour or so just on these questions.
Yes, and we will keep finding new and new answers.
Yeah.
Right.
Ma'am, Dr. Sanu is here.
Dipankar sir, you were saying something, Dipankar sir?
He has already
Thank you,
left.
Shiva. Okay, Dr. Sanu, you joined us. Sanu ma'am.
Yeah, namaste. Please come to Nepal.
Yes,
I think we can do a physical CME in Nepal. Let's all.
Don't worry.
Right,
We have 2 days conference. It will be nice if you people can join. It will be a great pleasure.
Thank you, everybody.
Thank you.
So I'd just like to
Bye.
take this opportunity and remind everybody of a few of our products. The Naari division of Jagsonpal has PRORETRO, Dydrogesterone 10 mg tablets. Then we also have Endoreg. Endoreg is a brand of Dynogest 2 mg, very well known for endometriosis medical management. And Cysteria M, the right combination of myoinositol and D-chiroinositol for restoring the reproductive health. So thank you all so much for being here today. And thanks a lot to the societies for associating with us, Dr. Sonu and Dr. Seema Mittal ma'am. Next we have this Saturday. Next Saturday is Scientific Sangam on umbilical cord part 2. So do join us. This is the webinar ID. You can take it from the Facebook link also. Visit that and register, please. Thank you very much.
Dr. Chhabra, may I ask you one thing?
Yes, ma'am.
Dr. Chhabra, how this is different, this micronized dydrogesterone from other gesterone?
Ma'am, it is micronized. That's why the bioavailability.
So how it works, whether faster or whether less side
bioavailability
effects or
ma'am, the bioavailability increases because of the micronization.
And side effects are less?
Yes,
also
definitely.
the dydrogesterone does not have much side effects, I know.
The dydrogesterone side effects would be just like any progesterone. That's
No, dydrogesterone has lesser side effect than the micronized other
Yes,
progesterone.
natural
Yes.
progesterone. That's true.
That's the
That's
natural.
true.
Yeah.
That's true. It's very well tolerated and it's also much more efficacious. Just like 10 mg of progestin goes into the patient, not 200 and 400. So that way, dydrogesterone scores over natural micronized progesterone. And then it is oral, so that is also a compliance
Natural
problem is
oral
not there.
micronized progesterone, I think, is not available anywhere in the world except in India.
Except in India,
People are
that is
using
true.
vaginal or
That is true. That is true.
So this is also available only in India currently, or it is made somewhere else also?
Ma'am, Jagsonpal is manufacturing the API only for the internal domestic market right now, but ours is the micronized progesterone. So that is what.
Great. Okay.
Dydrogesterone. So thank you all very much for joining us, and we hope to see you again.
Thank you,
End the
ma'am.
meeting, ma'am?
Thank you, ma'am.
Bye bye.
Thank you, ma'am.
Bye.